Hi there. Now, some of you might have already seen my video in which I talk about why I do the work that I do. And if you have seen that video, you will have some sort of an understanding as to why I'm so passionate about the things I'm going to talk about in this short video series. Now, I'm not sure how many videos it's going to be just yet. We'll see how it goes, but I'm going to keep them quite short because some of the material can sometimes be a little bit tricky to understand and to kind of absorb. So I'm going to make them as short as I possibly can in each one. So in that video, if you haven't seen that video, it's actually on the page on my website which talks about why I do the work that I do. It's on emmajanes.com. But if you haven't, it doesn't matter. You'll soon catch up. The main thing is that I feel it's really important that we share our lived experience and we tell personal stories. And for me, in a slightly kind of converse way to what we normally think of as credence, I really do feel that adding in some kind of snippets of my personal story do add weight to what I'm going to be talking about. And that's in addition, of course, to all of the various qualifications I have in things like psychology and counselling and coaching and all different things, as well as work and training, vocational training in various mental health fields, and also actually work on the front line in mental health services of various different kinds across the public and voluntary sector, and also in my own businesses. So the reason why I feel it's really important to add those personal stories in is because it indicates that I have actually seen things from both sides of the equation. So I'm not just talking about textbook issues where I've read something in a book and then I've tried to apply it somewhere. I've actually lived and witnessed a lot of the things that I talk about. I've lived with very, very severe mental health challenges. I've recovered from very severe mental health challenges, and I've also worked and I've trained in the field extensively. So I think that it's really important that we're sort of coming from that area. So I actually feel that I'm going to start off with this one. It's the first in a series on informed choice in mental health care. And you might ask yourself, well, you know, what does that mean, and why should I care? And, you know, I'm sure I already have informed choice about these things. And you may be quite surprised to understand in a little bit more depth what I actually mean about informed choice, the degree to which we are given informed choice in mental health care at the moment, and really how things should be changing for the better. So in doing this video series, I kind of decided to put my money where my mouth is, so to speak, and to actually start talking about this and actually getting out there the kind of research that I've been doing over the last decade or so, the experience that I've had over the last 15 to kind of 25 years, and you know, kind of putting it all together, because I think it's quite an important time to do this now. And I guess the thing that spurred me on right now is, aside from having quite a lot of time during the lockdown to sit and muse a bit further about some of these things, I'm starting to hear some quite disturbing news articles, headlines in the news that are saying things like, there's a mental health pandemic coming, you know, we're all suffering, we're all struggling, everyone's getting depressed, there's anxiety and blah, 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 blah. And whilst that it's probably true and highly likely that most, maybe all of us, from time to time throughout this period have experienced, no doubt, quite a lot of stress and pressure from various things, and possibly some people have had even some traumas resurface. Some people may have been living with abusive people. They may be in a state because they've lost their businesses. There's financial challenges all over the place, and on and on and on. Not to mention, parents who have had to be home all the time, trying to homeschool, trying to work at the same time, trying to keep themselves looked after as well as the children and everything else. So you know what I mean. I'm sure that some form of emotional distress, some stress and pressure has touched us all over this time. And I think what it's really, really clear to understand, and I will keep repeating this like a stuck record, is it's absolutely normal for you to feel like that. It's absolutely normal. Now, that's not the same as me saying it's all fine and let's just think positive and blah, 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 blah. It's not that. What I'm saying is, if you are feeling stressed, even if you are feeling extremely depressed and low and very, very anxious, it's important that you understand that this is an absolutely normal reaction to a very abnormal situation. And on top of the virus, there's all sorts of other things going on in the world that may or may not be touching us to a greater or lesser degree. And so I kind of hope and I urge you to really, really consider the approaches that you are going to take to manage that if you feel that there's a significant enough challenge that you need to do something about it. And that's kind of why I'm doing this now, because I'm hoping that I will reach some people before they simply reach out for the tablets, okay? And as you see as we go along, I'm not advocating that there isn't a place for those in some exceptional circumstances, but as a rule, with the sorts of things that we're experiencing right now, there are a gazillion other things that you could do before you get to the point of taking tablets, and they really should be as a last resort. Now, I'm going to make a disclaimer here because I kind of fear some kind of litigation or anything like that. It's not because of that. It's actually, this is based on my own personal experience, right? You're going to hear all sorts of potentially challenging bits of information throughout this video series, and you may start to reconsider a whole number of things about the way you think about emotional distress and the ways to cope with them and all sorts of things. Now, I want to make it very, very clear that if you are currently taking any form of psychiatric medication, and by that I mean things like antidepressants, things like benzodiazepines, things like mood stabilizers, antipsychotics, anti-epileptic tablets, which they sometimes use as mood stabilizers, anything like that, okay, you must absolutely not simply come off them without first taking advice, okay? It's very, very dangerous to come off any of these tablets, what we call cold turkey. You know, you cannot simply just chuck them in the bin, all right? And I've said for a long time that I'm going to do a video about withdrawal syndrome, but because I can explain a bit more about what happens in the brain when you just stop taking these chemicals. You've got to remember that your brain is used to having these chemicals in there, and when you simply remove them, the consequences can be life-threatening, actually. So I want you to be just to know, under no circumstances must you simply throw your tablets out. You've got to keep taking them as you were until you have found somebody who is willing to help you taper off them very, very slowly. Took me 2 years to come off medication, and even then it was tough. It was very, very tough. Okay, so that's my disclaimer, and I may say that a number of times throughout this series, but I just want you to know that that's important. So, excuse me. Moving forward, back in February of this year, I wrote a very long article. This is on 2 pages on 1 page, so it's about 28 pages long article. And what this article did was to basically bring together, it was almost to summarise some of the major points that have come out of the psychiatric research, the mental health research, over the last kind of 40 years, really. And some of them are from very recently. Now, what I actually did in the article was that I picked, I kind of gave a brief overview of a number of the main points, and then I only focused on 4 points at greater length, which are the kind of 4 most prominent ones, I guess. So I followed through, I used a case study of a hypothetical person whom I know a great deal about, and followed that story throughout it. And I also have given lots and lots of references. There's a bibliography at the end full of scientific research articles, books, videos by authors and practitioners, psychiatrists and psychotherapists and things like that. And it talks a lot about the diagnostic criteria, and what we mean by that is the labels that we give mental health challenges. So you may have heard of things like depression and schizophrenia and bipolar disorder and borderline personality disorder, ADHD, generalized anxiety disorder, all of those sorts of things. And what we have discovered over the last few years is that, well, few decades really, is that these ways of describing mental health challenges are not reliable ways of talking about the experiences that we have. So there is no evidence which kind of proves that there are distinct categories of disease, and that's kind of the main point. Is there is no medical cause of mental health challenges, and so therefore we cannot treat them in the same way as a disease. Okay, and I will make this a bit clearer as we go through the series, because I'm going to talk about certain things in greater detail. But first of all, I'm going to read out just the 13 topics that were covered in a huge article by a group called the Council for Evidence-Based Psychiatry. And this is a group of psychiatrists and other practitioners. There's a medical anthropologist and other academics, as well as people who practice on the front line now, who have also brought together the scientific evidence, and they've come up with the 13 points that show that the classification of mental health challenges needs to be challenged for a start, and even that the people who wrote the diagnostic criteria in the first place are also coming forward and saying, actually, you know, there was no scientific evidence to base it on, so we basically voted on them. So, you know, there's a big movement now coming forward to try and set the record straight about these things. So I'm going to, in each of these videos, talk a little bit about certain aspects of it, and then at the end I'm also going to talk about, okay, what do we do about this? Because it's all very well me educating you about what's wrong with the system, or, you know, that, oh, the evidence doesn't, the scientific evidence doesn't back all this up. But then, you know, we can't just leave it hanging there. We have to do something about it. Well, I feel that we have to do something about it because it doesn't detract from the fact that people are suffering. So if it's not a medical illness, if it's not, you know, a chemical imbalance or a biological something wrong with the brain or genes or whatever, then what is it and how can we treat it? You know, so that's where we're kind of going with this. So the Council for Evidence-Based Psychiatry, and you can just Google that and look them up, they came up with 13 points which they felt needed to be kind of constructively criticised based on the scientific evidence or lack of scientific evidence. And these 13 points are as far as, I'm going to read it from the article, so bear with, that 1, there's no known biological cause. So there are no known biological causes for any of the psychiatric disorders apart from dementia and some rare chromosomal disorders. Consequently, there are no biological tests such as blood tests or brain scans that can be used to provide independent objective data in support of any psychiatric diagnosis. That's the first one. Now, all I'm going to do at this point is just to read through this list, and then all the subsequent videos will be going into some of them in more detail, probably not all 13 because that would be an incredibly long series, but at some point I might get through them. So the second point is the myth of the chemical imbalance. Psychiatric drugs have often been prescribed to patients on the basis that they cure a chemical imbalance. However, no chemical imbalances have been proven to exist in relation to any mental health disorder. There is no method available to test for the presence or absence of these chemical imbalances. 3. Diagnostic system lacks validity. Psychiatric diagnostic manuals such as the DSM and ICD, that's the Diagnostic and Statistical Manual and the International Classification of Diseases, are not works of objective science, but works of culture, since they have largely been developed through clinical consensus and voting. Their validity and clinical utility is therefore highly questionable, yet their influence has contributed to an expansive medicalisation of human experience. 4. Psychiatric drugs cause altered mental states. Just like other substances that affect brain chemistry, such as illicit drugs, psychiatric drugs produce altered mental states. They do not cure diseases, and in many cases their mechanism of action is not properly understood. 5. Antidepressants have no benefit over placebo. Studies have found that antidepressants have no clinically significant benefits over placebo pills, inert pills, in the treatment of mild to moderate depression, while they provide some benefit for severe depression, at least in the short term. Recent research also suggests that antidepressants may be associated with increased mortality, at least in the elderly. And we'll go into that in a bit more detail because I'll talk a little bit about the placebo trials, because it's interesting that actually the placebo effect may be even greater. The placebo may work even better because people can always guess when they're taking the active substance in trials. And I'll talk about that in case that sounds like gobbledygook in another video. 6. Worse long-term outcomes. There has been little research on the long-term outcomes of people taking psychiatric drugs. The available studies suggest that all major outcomes of people taking psychiatric drugs add little additional long-term benefit, and for some patients, they may lead to significantly worse long-term outcomes. 7. Long-lasting negative effects. Psychiatric drugs can have long-lasting effects on the brain and central nervous system, particularly when taken long-term, which can lead to physical, emotional and cognitive difficulties. And I can vouch for that. 8. Negative effects are often misdiagnosed. Psychiatric drugs can have effects that include mental disturbance, suicide, violence and withdrawal symptoms. These can be misdiagnosed as new psychiatric presentations, for which additional drugs may be prescribed, sometimes leading to long-term use of multiple different psychiatric drugs in the same person. Psychiatric drugs, this is point 9, psychiatric drug withdrawal can be disabling. Withdrawal from psychiatric drugs can be disabling and cause a range of severe physical and psychological effects which often last for months and sometimes years. In some cases, withdrawal charities report it may lead to suicide. 10. More medicating of children. Use of psychiatric drugs in children and adolescents has been rapidly expanding across the developed world. The potential long-term damage these drugs can have on developing brain has not been properly assessed. Furthermore, there is now evidence that increased use of medication within this age group may lead to worse long-term outcomes. Number 11. Regulator funded by industry. The UK regulator of psychiatric drugs, which is called the MHRA, is entirely funded by the pharmaceutical industry and employs ex-industry professionals in key leadership positions. Such conflicts of interest could lead to lenient regulation that places commercial interest above patient protection. 12. Conflicts of interest. Ties between doctors and the pharmaceutical industry are particularly widespread in psychiatry. In the UK, psychiatrists do not have to report to any agency or authority how much industry income they receive each year. And the last one, 13, manipulation and burying of drug trial data. The majority of psychiatric drug trials are conducted and commissioned by the pharmaceutical industry or those who have extensive ties with them. The industry has a long history of burying negative outcomes and of manipulating research to highlight positive outcomes. So I think that what happens in the CEP, that's the Council for Evidence-Based Psychiatry, they actually, in their article, go into much more detail in all of those 13 points. And in my article, I really went into 4 of the main points, which are based on an article about the 4 false pillars of biopsychiatry. And these 4 points were, first of all, that the inheritance pillar, the myth that mental illness runs in families. The second one, going back to the inheritance one, not just mental illness, of course, does run in families, but it's about the fact that there's an assumption then that it must be inherited, and there's been no evidence for that. So number 2 is the chemical imbalance pillar, and this is based on the premise that medication works by correcting a chemical imbalance, therefore mental illness must be a disease. Okay, these are the myths. And the third one is the defective gene pillar. Defective genes have been found for some disorders, therefore mental illness must be a genetic disorder, and that's the myth. And 4, the brain imaging pillar, that evidence of a diseased brain can be detected using modern brain imaging instruments. And those are the sort of 4 myths that I focus on mostly in the article. And I go through in some detail looking at all of the evidence which has shown over the last 40 years that these things aren't true. So I'm going to leave it there now because, as I say, I wanted to keep these quite short. This is probably going to be one of the longest videos because it's the introductory one. But I just want to say that, you know, be prepared to have everything you thought you knew about mental health and mental ill health and emotional distress, whatever you want to call it, psychosocial distress, and I can use those terms interchangeably because they're a bit more accurate, challenged. Because even if, as I say, even if you have been to your GP or you know someone who's been to a GP and they've had a consultation with them and then they've been diagnosed as having a mental health condition and then given some medication, what you must understand is that it's highly unlikely that the GP knows how to give proper informed consent either. And even at the level of psychiatrist, either the psychiatrist doesn't know about these bits of research, or they might have heard them and they've chosen not to use them, because psychiatric training still uses a lot of the research and material that is kind of pre this data, so it predates the kind of material that has been building up over the last 40 years. So that's just an introduction there. And I am really quite excited to bring this information out. And as I say, I'm a very solutions focused person, and that might sound like a bit of a cliche, but we will be getting on to, okay, once I've understood this, once I've understood how I can direct my healthcare, and that's what we're looking at. It's about understanding the information so you know how to ask for what you need, and you can even have a broader choice of the options that are available to you once you know about them. So as I say, we'll be moving on to what the evidence actually is, what we know the root cause of mental and emotional distress to be, or root causes, and how we deal with them. So I'll very much look forward to getting into that with you later on.